Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, everyone. Thank you for joining us for another episode of Breast Cancer Conversations. I am joined with Dr. Kohli, who is joining us for today's conversation, where we're going to talk about all things kind of cancer survivorship, cancer care, treating the whole person. I know, and if you have listened to my podcast before, you know that a lot of times we are diagnosed with breast cancer and it's like treatment decisions, surgery decisions, scan after scan after scan, and kind of rinse and repeat. But what about all of these other like lifestyle components that we need to take into consideration, our mental health, our emotional health? And then also for someone like myself who was diagnosed in my 30s, you know, we're going through all of these treatments and there's going to be long-term lasting side effects that we're going to be managing like years out. And so I remember almost falling off the table when my doctor told me I was going to be on some hormonal therapies for the next decade. And I was like, wait, a decade? Like counting down the radiation for like a month, I got, but like 10 years, totally different story. Welcome to the conversation.
Thank you so much for having me. It's you're a prime example of why I do what I do, because when I started as a breast surgeon, I really thought most of my patients are going to be older than me. And I started to see patients that were younger and younger and younger. And now, you know, I'm taking care of a lot of my peers. You know, unfortunately, I saw a friend today, and I always said I love becoming friends with my patients, but I don't like when my friends become my patients. And so it's important to know that, you know, it's happening younger and younger. The incidence of breast cancer under age 40 is increasing by 2% per year over the past decade. And we really need to focus on what are the implications of what we do to take care of women with breast cancer, because survival rates are excellent, outcomes are great, but it's more than just getting through a breast cancer diagnosis. If we're telling our patients that you have a great long-term survival rate, we need to look at the quality of those years that we're working so hard to save and your quality of life, and not just saying, yeah, you got through it. Good.
Oh, exactly. Well, I can tell already we are going to really enjoy this conversation, because that's exactly what we talk about day in and day out, especially in like our support groups or expressive writing classes, really just kind of having people come to our organization, survivingbreastcancer.org. Like, quick side note, just to interrupt, if anyone is interested in any of these free programs, you can head on over to survivingbreastcancer.org/events. Even 2 years after their diagnosis, when they're still dealing with all of the trauma and things that are hitting them kind of bubbling back up again, the fear of recurrence or the fear of progression, etc. So I am so glad to have you here tonight. But before we dive into all these juicy questions, why don't you introduce yourself, what institution you're with, and maybe a little bit about your background, where you got your training from, and where you are now.
Well, thanks for having me. So I'm the director of breast surgery at Monmouth Medical Center in New Jersey. So I'm part of the Robert Wood Johnson Rutgers system. And it's my 10th year in practice. I got into breast surgery because I'm a surgeon, love operating. I was raised by a very medical family, and my father was a plastic surgeon. And I saw how important it was to not just take care of a patient, but restore them and make them feel like they're a version of themselves they can recognize. So I did my general surgery training in New Jersey. I did my breast surgical oncology fellowship in Manhattan at Mount Sinai, St. Luke's Roosevelt, Beth Israel Medical Center. And I came right back home to where I did my general surgery training, where I've been in charge of the program for almost 10 years now.
Incredible. Thank you for that. It's always fascinating to see, and I think for like other women just listening to this, or young adults too, just to be inspired by, you know, women really following their dreams and how they get into the fields that they get into in the medical profession. So thanks for sharing that.
Oh, of course. I'm one of those people that has always loved using my hands. I've always loved to have a relationship with people, and of all the specialties, this is one where you actually are able to really develop that long-term longitudinal relationship with people. And it's very rewarding to see them not only do well from something acute, but really continue that long term. So
and something you said really resonates too, right? Is making the person feel whole again. When you find out that you have breast cancer, surgery is most likely going to happen, depending if you're early stage, if you're late stage, maybe not necessary because it has already spread to distant parts of the body. However, if surgery is an option, first and foremost, we want to get the cancer out of our body. And, that's at the top of our mind. But then after that, like once it kind of sinks in, it's like we're losing a part of our body. It impacts potentially our identity, our femininity. If you've had children, if you haven't had children, if you're planning on breastfeeding, etc. If you're in relationships, how is this going to impact when you're dating? Or if you are already in a relationship with somebody, how are they going to take the news and respond? And through the work that I do on the podcast, I feel like I still get surprised hearing some of these outlandish stories of like, I want to say like nothing surprises me anymore, but I talk to so many women and everyone's experience is so unique about, they woke up from surgery and even hearing like, oh my gosh, this looks great. And I'm like, it's black and blue and bruised. And like, no, this does not look great. Right. And so like, how do we really like set up these expectations, work with our surgeons who work so closely with us, with our plastic surgeons, and everyone on the whole team to kind of know what revision surgery looks like, what does it feel like to have the expanders? What does it feel like to go through the reconstruction? What all of the options are? And a lot of times, and I was fortunate in the sense that I had neoadjuvant chemotherapy. So I actually had about a good 6 months of chemotherapy before surgery, giving me the time to investigate and deliberate all of my surgical options, which were still kind of a big question mark depending on how I responded to the chemo. However, it wasn't that like, we got to get you in here now. What type of surgery do you want? And so if you could just talk to me a little bit about like a day in the life when you first meet with your patient and go through some of the options with them. You mentioned that you really like to build these relationships with them. Talk to me through like what that initial appointment looks like and what someone could expect.
Oh, absolutely. And I just as your experience and it opened your eyes to how multifaceted this whole experience is. It can be very overwhelming. Not just dealing with a diagnosis and what comes with that treatment wise, but the big picture and all those nuances that it's very hard to keep track of every little thing, fertility preservation, your body confidence, keeping your hair, preventing lymphedema. All of these things are so nuanced and individualized. And, a day in the life of, or basically an interaction with myself and my patients.
Yes.
Because there's so much. I think anyone who is just going for their mammogram is afraid to get a call back. And you get a call back and then you get a biopsy and then you're afraid to hear that it's cancer, knowing that we're going for a mammogram to detect cancer and hopefully find it early when it's most treatable. But it's still something you don't ever want to hear. And then there's all those what ifs that come with it. And the what ifs are really sometimes very rooted in our preconceived notions of what breast cancer looks like and the people you've seen who have come through it. So I see a lot of women coming in extremely fearful that this is going to be like their grandmother's experience, where we didn't have a variety of options. There wasn't a lot of attention to how well they get through it. It's will you get through it? And then not so much about, the other aspects of the collateral damage that comes with what we're doing just to get you through a cancer diagnosis. And you think of a very disfiguring surgery. You think of people always getting chemo and being very, very sick and radiation burns and lymphedema. And these are things that I have to start off the visit by saying, it's not like it once was. It is very different now. And unfortunately, breast cancer is so common, but we benefit from all the women that came before us because we've learned how to treat breast cancer so much better. with better outcomes. And no matter what stage or biology, we can do better and we can hone in more specifically on the cancer and also more specifically on the individual. So we're not just going through an algorithm of you have breast cancer, you're getting a mastectomy, you're getting chemo, you're getting radiation. We really can fine tune it to make sure that we do a really good job treating cancer, but also a really good job of taking account of that patient who's a person who has a life, who has potentially a family or a partner or their own goals, and all of these things matter. So I think every intervention you have to think of the long term, because if I'm telling you, hey, guess what, it's a great thing, that you at least caught this stage 1, we can do a lot to really get you through this with hopefully not as aggressive a course, but then there's a lot more that comes after that, and so you have to think of every intervention. Is this patient going to need chemo? Is this patient going to need the full lymph node dissection or a sentinel lymph node? Or do we even need to remove lymph nodes? And how can we make sure that it's that kind of subconscious reassurance to patients that I'm actually thinking of your long term. I'm planning on you being here long term. And that is something that I focus a lot of the conversation about. Is it may not be so important to you today where you're thinking, I just want to get through this, but it will be important to you in 10 years when we're reminiscing about how it seemed like yesterday. And those are the things that matter.
One of the things that I hear, not being a surgeon, but a lot of times is we will get an initial staging or an initial prognosis. But then a lot of times, and I didn't realize this even in my own case, that it wasn't until like you actually go in there and you see what's going on with the cancer, that can really change, where I might actually need chemo afterwards, or I might not need chemo, et cetera. And so how do we balance like all of these what ifs and uncertainty when we don't have the complete information just yet?
Yeah, it's hard because you don't want to lay out every potential scenario for a patient, because an unlikely, scary scenario, it just is another reason to lose sleep at night. But I always say each step tells us more about what the next step is. And I can broadly say, I'm expecting, the phases are find it, remove it, prevent it from coming back, and watch to make sure it stayed away. And what do we need to do to accomplish each one of those goals? And watch to make sure it stayed away. And all that phase is also getting into a normal life again, and that survivorship phase, and making sure that we're restoring you back to something that you recognize and that you feel comfortable with, without feeling like you have these, battle scars and, a lot of kind of just long-term sequelae of what we do. So, the surgery is important, but again, planning the surgery, you're doing that based off of imaging estimations of sizes. And, no imaging study is 100% and can't, necessarily pick up every detail. And you do get a lot more information when you have that out. And so there's a lot of branches in the road where things could go. And knowing that you can have a surprise, and it's more common to have a surprise along the way than not,
Okay.
because breast cancer doesn't play by a rule book. There is no exact, this is what I'm expecting is going to happen. So as long as you have a supportive team around you, supportive people around you, and the right attitude, you'll be able to get through anything. Okay. But yes, it can be extremely frustrating to not know every detail at one moment. So there are a lot of what ifs, but then you find that you pop out on the other side of things. And you had mentioned earlier, you in your support groups, you're hearing people 2-3 years out still reeling from their diagnosis. And I'll tell you, that's exactly what I see. It's usually very fight or flight that first year, with having to go through various components of your care. And once the dust settles and patients are kind of returned back to go back to your life now, you're now just on take a pill for a few years, or, we're going to now start just doing surveillance imaging. That's when I see it catch up with people where they realize that I don't know how I got through that. Was that a bad dream? Did that really happen? How did I do that? How was I so strong? How did I manage? And somehow I'm here. And that's where there's a lot of PTSD that comes into play, and people are now then managing their reaction at that point. And so it's not at all uncommon, but I think that's the moment to now say, you are at this point, and now we may need to work on that. We may need to now work on your processing of how you went through that journey. And are you happy with where you are? And what can we do to supplement, to make you feel at peace and also make you feel like you can move confidently into the future?
Thank you for that. And I think that's going to become like a tagline that we share of, we're getting more information every step of the way, because who doesn't want more information to make these decisions, right? And so when we frame it in this way of like, the surgery is going to tell us even more, then there's going to be tweaks and changes. I think for the A types of us out there where we want everything right away and we can't handle the change, I think just putting that frame of mind is really helpful.
Oh, completely. I would want that. I would want to pivot. If we learned some new information that could change my outcome and do better for me, if I were in those shoes, I would want to pivot. If we can come up with something better, I'm all for it. And I think it's also, it's all about attitude and being able to anticipate that that can happen, and that's okay.
The other question that I would love to ask you, as you're advising women and trying to have them become restored in the best version that they want to see themselves, how do you decide or help them decide on the type of surgery to have? And just very broadly speaking, between a lumpectomy or breast conserving surgery versus a mastectomy versus a double mastectomy.
Yeah, I mean, there are no good options. It's breast cancer, and no one wants to be there in the first place. So it's acknowledging that is the first step. But what can we do to make the best of the situation? And I often hear the first thing is just take them off, both of them, done. And it's because you don't get a say. You don't get to decide if you've gotten breast cancer, and you don't get to decide if it's triple negative or if it's hormone positive, how big it is when you find it. There are no decisions you really get to make other than the decision of what surgery you're having. There may be some things that you can't really negotiate on if you need more nodes removed or less and whatnot. But a lot of women have this kind of, they feel the pressure of, now I have to make this decision that my outcome is really hinging on. And because you feel like, I'm doing a bigger surgery, I'm doing more, then that must be a better option. And then there are patients where they might know that they don't need to do that, but they might want to do that because it might be more empowering to say, you know what, even if the survival rates are the same with this surgery versus this surgery, if I could never do a mammogram again in my life, good, that's one thing I want to control. And if I could maybe potentially avoid radiation by doing a mastectomy, I would love that. But it's about having the right information and not just leading with fear, because you don't want fear-based decision making. You want it to be about what's actually going to be right for the cancer and the individual. And so what I explain to patients is the two broad options: lumpectomy, mastectomy. And if you're doing a lumpectomy and radiation as one package, that in the setting of someone without a genetic mutation carries an equivalent survival rate to doing a mastectomy. So doing that bigger surgery doesn't mean you're doing more to treat the cancer. There may be some other appealing things. Say you always hated how your breasts look and you wanted to have mastectomy reconstruction. You don't mind having those additional surgeries. That might work for you. But it's a big decision to part with your breasts. It's not like, having an appendectomy. It's a part of your body that you will miss because it's a part of your identity. It's a part of who you are as a woman. It's not something that you didn't even realize you had. And even if you can do that beautiful nipple sparing mastectomy and it looks great, it doesn't feel the same. It's numb, and it's not, doesn't feel like you. So there's no great perfect option, but what can we do that fits for the total picture and for the individual? And you really have to listen to the patients and hear what is important to them too, because we can certainly kind of modify and adjust things and get to a happy place afterwards, where sometimes it's, I've always hated my chest, but I don't want to do mastectomy, but I've always wanted them smaller, so do a lumpectomy reduction, and we can find a middle ground in a lot of cases.
You touched upon, kind of when you meet with your patients, like the year after, if they're coming back in to see how everything turned out, or if they're just checking in with you as part of like a routine follow-up. But that's kind of when you start to notice more of the lingering trauma, I would say, of the diagnosis. So can you talk to me a little bit about how you help navigate and support that patient afterwards, when we are thinking about that whole person, not just like the immediate get the cancer out, but like what next?
Oh, sure. Well, I think you have to start at the moment of your initial consultation with the expectation for the long term. And I think that is important for patients to know, that we're not just trying to get you through this. We're really looking at the big picture here. And the needs that come after that acute phase of care, they vary. They vary. It could be a lot more of an emotional need, where I'm leaning on my social workers and setting them up with, maybe the nurse navigator needs to spend more one-on-one time. Maybe they need to have, a therapist and talk therapy or support groups. And that should be something that's not frowned upon, or that patients feel self-conscious about, or feel like they aren't doing a good enough job of managing it on their own, because it is a very difficult thing. But there may be other aspects where there's weight gain related to the medications you're on, or the inability to get back into your normal routine activity wise because you've had to recover from surgery. I mentioned lymphedema because I think that's really important, that it's often the last thought patients have. They aren't always thinking about a swollen arm. It's the last thing that really comes to mind is lymphedema, but it's a huge component. If that happens, 1 in 5 women who have breast cancer can get lymphedema. And if you're right hand dominant and you get swelling and you can't close your hand, you have heaviness, it's interfering with your ability to take care of yourself and do basic things, that's a really big deal. So I always, start out with a measurement of what is a normal baseline in terms of lymphatic volume and fluid with bioimpedance spectroscopy. And the patients know from that first moment that I'm planning on using this in the future. I'm planning on looking for these signs before they have overt symptoms, before they are, feeling heaviness, before their jewelry is tight, so that if I can detect it when it's subclinical and at a phase where it's very easy to reverse with minimal intervention, it's a better thing for them long term, because that's one thing we've avoided. We don't need to have that extra burden of, now you have to do physical therapy, now you're wearing compression all the time, now you might need a lymph node transplant. So just being proactive and thinking of all the potential outcomes down the road, it's important. You need to really be not just laser focused on the cancer, but what is going to come in the future. So all of the, every aspect of it, from, chemotherapy induced alopecia, and regrowth after chemo, radiation effect, all of these things are really important to be cognizant of and discuss with patients, and have them also be aware of as part of their, this could be part of their long-term story. But if we are educated and empowered, you can do a lot.
So before we dive into like some of the nitty gritty, because you brought in such great topics on just lymphedema itself, can we take a step back, if you can define for my listeners, what is lymphedema, how it can potentially occur, and why it's risky with some of the surgeries? And then when you do this measurement, is that before the surgery or immediately following? Like, when does that intervention come in for like the baseline?
So lymphedema it's a swelling of an extremity because of basically a backlog of lymphatic fluid. So, our lymph nodes, they have several purposes. There's the immune function, but they work as fluid pumps. And in terms of, how this is important for breast cancer, if a cancer cell were to leave the breast, we know the next place it would most likely go are lymph nodes under the arm. So a major part of what our treatment is staging that cancer by sampling lymph nodes. Sometimes there are no abnormal lymph nodes on imaging, but we still need to remove a sentinel lymph node or lymph nodes because it's an invasive cancer. And imaging doesn't always pick up on a cellular level if there are cells there. Other times there are patients that we have known lymph node involvement, and we have to remove more than just a sentinel lymph node and even those connecting lymphatic channels. And, these lymph nodes, they don't regrow. Okay. And lymph nodes that drain the breast can also drain the arm. And even though there are some that are more likely to drain the breast tissue and others that will still remain and drain fluid from the arm, it could definitely impact the lymphatic drainage of the extremity when you're removing lymph nodes from the axilla for breast cancer. So, I kind of explain to patients, say you get a bug bite on your finger, right? Your body is identifying the toxin from that bug. It's sending fluid there to dilute the area so you get swelling. But then the next day it settles down, it goes away. That's your lymph nodes at work. They're finding out what's wrong, they're trying to fix the problem, and they're washing that area out. If that happens after we've done something to the lymph nodes, it may not be able to return that fluid as well. So little things can kind of incite a lymphedema event. And it leads to a lot of fear of, should I even get a blood pressure on that side? Should I get an IV on that side? Should I get my nails done? Because you're worried every little injury could lead to lymphedema. And, there are a few main things that we need to remember is lymphedema risk is directly correlated with the number of lymph nodes we're removing. Then you add some additional risk factors. When you add chemotherapy to the picture, that increases the risk about 5%. When you add radiation to the picture, that increases the risk about 5% more. And then you just have some patient characteristics where one person might be more prone than the next, either BMI or habitus or just, how they're made. So we used to only think of those super high risk patients, the ones that get a full lymph node dissection and are getting chemo and radiation and have so much scarring in there, that those are the highest risk patients. But I'll tell you, most breast cancer surgeons can attest that you might have a patient that you think is the highest risk patient for lymphedema and they never get it. And then you might have someone that only had one lymph node removed, didn't need chemo, didn't have a super aggressive course, and they struggle with it. And so it's hard to predict who's going to get lymphedema. Even if someone's more likely than the next, it could be someone who doesn't have a really aggressive axillary nodal management. So I check everyone. And so what I use is, I use SOZO. It's a bioimpedance spectroscopy unit. And what it does is it sends a bioimpedance kind of electrical impulse, almost like those body analysis machines you see at the gym where they tell you your fat percentage and your muscle mass. But this is looking at your lymphatic fluid volume, and it's done in under a minute. I take a baseline measurement at the time of the initial consultation. So the patient's normal status is known and it's documented. And then through the course of their care and their follow-up, we're doing repeat measurements. So it's kind of like the vital sign for my patients in terms of their lymphatic status. And so what we used to do is just measure with a measuring tape. Someone would say, I have a swollen arm, and we'd measure it and say, okay, yeah, it's more swollen than the other side. But you can have other causes of swelling that don't necessarily mean lymphedema. So this is a much more reliable assessment because you're getting very exact measurements and it can detect very minute volumes of fluid before you're really developing symptoms, before there's noticeable external swelling, before there's heaviness. And so it can detect, like, I want to say it's like 2.5 tablespoons of fluid between one arm and the other. And when we find lymphedema at that early subclinical phase, it is reversible with compression. So we have the patients fitted with a compression sleeve. They wear 12 hours a day for 4 weeks, and then we recheck it. And usually the lymphedema is gone. It's usually that the patient is back to their normal baseline. And so if you reverse it, then you're able to maintain that normal status. But it's when it goes undetected, lymphatic fluid can form its own structure where it becomes very, very difficult to work out of that space. So the lymphatic fluid is very protein rich, and it can form kind of that jello structure where you can't easily push it out. And if you're in that later phase, then it needs a lot more work to reverse. So lymphatic pumps and advanced procedures like lymphovenous anastomosis, lymph node transplants, which all those things we want to avoid. We want to make it something that's super easy, pick it up early, and have a quick, not aggressive intervention to restore the patient back to their normal and say, carry on. Not so much impact on your motor function, your strength, and not to mention how inconvenient it can be if you have to go to physical therapy 3 times a week for arm swelling. It's one of those things where it can definitely change a lot for a patient if you're being a little bit more proactive.
If it does reverse after the 4 weeks, in your example, after she wears like the compression sleeve, are you still doing like these check-ins regularly because it can come back? So it's this constant like catch it early, reverse it, catch it early and reverse it type of pattern?
So if a patient develops lymphedema, it's most likely going to happen within those first 3 years. 95% of cases will happen in the first 3 years of treatment. So it's, of course, super important to follow patients no matter how long out, because it could be 10 years later and you could have, some injury and all of a sudden you're getting swollen, but you're not able to have that relieved. It can happen down the road, but it's more likely to happen earlier on. And so it is part of the routine follow-up where it's happening every visit. Ideally, it should be every 3 months. If someone has an abnormal measurement and we're doing some kind of intervention, I do check them sooner to make sure that intervention's working. If I'm saying you have swelling, you can't tell, but I can. You need a sleeve. I don't want to subject them to a sleeve for the next 3 to 6 months until they just show up again. I want to make sure that I'm anticipating in 4 weeks it'll be better. So come back to me in 6 weeks. Let's check it. And then if you're good, I'm going to clear you to use it as needed. We're preemptively before air travel. Make sure you're just keeping, but we don't then just stop. We continue. And if the patient has a normal measurement, it's not as if I'm going to say you had a normal measurement, you don't need it anymore, because again, it could happen year 1, year 2. Of course, it's more likely in those early years, but it could happen anytime. And it's, I think, reassuring when patients come in and they're year 5 and they're like, yep, I'm still good. That's great.
And lymphedema can also happen in the chest area, correct?
It can. So you can have lymphedema. There's a few different types, right? You can have a congenital lymphedema where it's more truncal. You can have lymphedema of the extremity as a result of an intervention. And we're seeing a lot of breast lymphedema too, where you're seeing kind of fluid backlog in the breast. So unfortunately, this tool, SOZO, is not going to be the best for detecting breast lymphedema. But we do some of the same interventions, a lot of manual therapy, massage, compression, things like that. So again, it's just something to be aware of. If you're seeing like kind of that chicken skin look, like dermal edema, some patients are worried that might be a sign of like inflammatory carcinoma. But it is often breast lymphedema.
Okay.
So
Yeah, that's just good to highlight because I think so many times we just associate it with like the arm, the extremity. So for someone who's listening to this episode, for example, and wants to have a conversation with their breast surgeon who may not have yet done a baseline or has spoken to the patient about some of these risks, how would you advise someone to kind of like take this information and approach their doctor? Like, should this be something we're advocating for if it hasn't been proactively presented?
absolutely. So, I mean, always be your own healthcare advocate. You can never be faulted. And even if a patient comes in and they haven't had a measurement prior to surgery, you can still do a measurement with SOZO. You can still, but you're not comparing to that patient's normal zone. You're kind of comparing them to a safe zone of there's a range of what we expect to be kind of a normal safe zone of lymphatic fluid. But with all of the, these conversations that patients have with their physicians, it's okay to ask why. It's okay to say, why do I need, a lymph node dissection? Is there any alternative? Can we scale back? Can we target just the ones that were involved? Can we, so it's completely reasonable to broach any of these topics with your provider, and you should feel that comfort zone that it's okay. It's okay to ask, and because you might have a very good explanation. I might say, because I still think they're involved and I don't feel comfortable leaving cancer behind. And you might need that reinforcement that, we always want to be optimistic, but sometimes we do have to do certain things that you may not want and we may not want to do. But the goal is getting you a good cancer-free outcome and a long survival.
Well, Dr. Kohli, this has been such a great conversation. I think kind of taking us high level on just, breast surgery in general, kind of navigating some of these decisions with, I think you brought up a great point early on about wanting to have some level of control of a situation where we have so little control, and navigating those decisions about the type of surgery we can get is really helpful. But then also kind of demystifying some of these fears that we have of, oh God, now the world is still coming to crash down because there's all of these longer things that I need to manage as well. I joke that if you're not managing lymphedema, you're managing to prevent lymphedema. So regardless, it should be something that's in our vocabulary and we're proactive about.
Yeah, I mean, listen, it's if we can take some of the fear out of this journey, it doesn't make it that, it's a joy to get breast cancer, but you don't need to waste the mental energy and space being afraid, because it is better than it once was. And it's going to continue to get better as time goes on. And advancements are happening day in and day out, and we are doing a better job, and you are kind of the proof. The patients that have come through it that you'd never know, that look great and are healthy and active, so we just want to keep doing better. And yeah, there aren't many decisions that you can make, but I would say you can definitely eat well, stay active, and try your best to control that stress level, because that's also not good. And it feels like you're powerless, but there are things you can take control of and be an active player in your own care. And if those are the take homes that I give you, I would say that those are things every single person, whether breast cancer or not, should be thinking about, in terms of, I can do better too myself, but we all, have places where we can do better for ourselves. And, no doctor is going to tell you it's bad to move your body and to hydrate and to eat well. And all of those things are so important.
Yes, that's such a great thing to reiterate and assure our listeners as well. So, this isn't, to your point, like decades ago where it was like, no, you're going to be bedridden, you need to stay home, you can't move, you're going to be recovering for weeks on end after surgery. And I remember going on a walk afterwards. Like, I was in the hospital overnight, came home, and I think by day 3, I was out walking because I was just like, I need to get out of the house, I need to move. And my mom, who flew out to visit me and just kind of help immediately after surgery, she was like, oh, you can't go for a walk, like you just had surgery. And I was like, Mom, I had breast surgery. My legs are totally fine. My legs are fine. And, I tucked my drains into my little like pouch, and I bundled up because it was wintertime. So because it was winter, like no one knew, like I was bundled up. I had the hat on, like it didn't matter. And it was just so empowering to like get fresh air, take a walk, and just like be like, look, I'm doing it. Like, I got through this.
Use your body. These parts may not be top, but the rest of your body is good, and you use it.
Exactly.
And I always say to patients, I'm not doing anything to your stomach. You can eat.
Yep.
Have your favorite meal. I'm not doing anything to your legs. I want you up walking. I want you feeling like yourself. I want you to move your body, and it's only going to be better for you.
Dr. Kohli, this has been such an amazing conversation. Thank you for sharing your wisdom. I would love to invite you back so we can continue these amazing conversations in the future. Is there any last tidbits of advice or information you'd like to share and leave with our listeners?
No, I would love to come back. And, it's common. You're not alone, and we're doing better, but there's still a lot of work to be done. And for those that haven't been diagnosed, show up for that mammogram. Don't be afraid. And, your best odds are with early detection, and we go from there. So
amazing. Well, thank you so much. I appreciate the conversation today.
Thank you so much for having me.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400 plus programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.